My name is John Greenwood. I'm Professor of Cardiology here at Leeds General Infirmary and Leeds University, and we're in the cardiac MRI department today looking at how cardiac MRI can help investigate patients with heart disease, and particularly coronary heart disease, because that's one of our strong interests here in Leeds. Here in Leeds we have two cardiac MRI scanners that are dedicated for heart use. We have a 1.5 Tesla scanner and a 3 Tesla scanner. This is just a measure of the how strong the magnetic field is, and really it doesn't have such a huge impact on a day-to-day basis from our clinical patients, but the stronger field strength scanner is really helpful for some of our advanced imaging research that we do. Most of the research that we're really interested in Leeds is based around perfusion imaging, so patients with suspected coronary heart disease or furring up of the heart arteries. We do a lot of developmental work on optimizing the perfusion protocols and then testing them out in clinical routine to see whether some of the changes that we've developed are step changes that can benefit patients in the NHS in terms of improved diagnostic accuracy. And we've done a lot of studies here over the years, perhaps the most notable one being the cemark trial that was published last year in The Lancet, and that was a large single centre study of 750 patients, all who had a cardiac MRI scan and the standard perfusion technique for looking at ischemic areas of the heart, which is a nuclear perfusion scan, and then they all went on and had an invasive coronary angiogram. And what we showed in the cemark trial was that actually a cardiac MRI scan is much more diagnostically accurate than our standard nuclear perfusion techniques. So this is really exciting now, because it potentially means that we can improve the diagnosis for individual patients and ultimately get their management better by using some of these advanced imaging tools. Well, we're doing a lot of large clinical trials here in the setting of myocardial infarction, so we're doing a number of UK multi-centre studies looking at how we can optimise reperfusion and reduce the amount of scar that's resulting from the myocardial infarction. We're doing another large clinical trial called cemark 2. This is ongoing now and is a British Heart Foundation funded UK multi-centre trial of, again, using MRI to get the diagnosis hopefully correct in patients with suspected angina, and that's a randomised trial of MRI versus the UK NICE guidelines. So what we believe is that if we use MRI rather than the current UK NICE guidelines, we can limit the number of patients that go through the cath lab unnecessarily, and that will have a real benefit for patients but also for the NHS as well, because it will potentially save the NHS a lot of money if we don't have to unnecessarily investigate patients invasively. So in Leeds we scan probably just over 2,000 patients a year from an NHS perspective, and probably 1,000 to 1,500 patients a year from a research perspective. So most of our patients who are being investigated for ischemic heart disease have quite a simple protocol that we can usually do in around about 40 minutes, 45 minutes, something like that. And that usually starts off with a stress perfusion study, so we're looking for areas of ischemia on the heart. Once we've done the stress perfusion study, then typically we would do the left ventricular volumes to look at the function of the heart and how well the heart is actually contracting. We may then go on and do a rest perfusion study, so again just looking so that we can see whether there's areas of inducible versus fixed defects. And then finally we would do what's called Lategadolinium enhancement, and that's an imaging technique to look for focal myocardial fibrosis or scar tissue on the heart, and that's very good at picking up whether patients have had a myocardial infarction in the past. And putting those components together, as I say, we can generally image the heart in around about 40-45 minutes, something like that. And it will give us what we term a multi-parametric view of the heart, so it'll tell us about the function, the anatomy, but it also will tell us about the perfusion and the morphology of the muscle itself as well.